first two speakers have presented from Hammersmith and Charing Cross respectively, and we're going to now move to St Mary's Hospital. And it's my pleasure to welcome Dr. Jeremy Cox, from whom we've all learned a lot from his wisdom. He's a fantastic educator and endocrinologist, and he's going to talk to us about hyperparathyroidism management.
So thank you for your kind introduction, and thank you to the organisers. I'd like to talk about risk assessment and guidelines in this in asymptomatic primary hyperparathyroidism. And at St Mary's we have a clinic where we have a dedicated parathyroid surgeon in the clinic with us, and post-operatively we follow them in either a joint stone clinic or a metabolic bone clinic for whichever complication they have. I'd like to discuss a case and the relevant guidelines for surgical intervention and management in the case. I'd like to show you a couple of new studies since the guidelines were published, follow up of the case and see what happened, and then also look at and review the evidence for bone risk and the effects of surgical intervention. So Mrs. LG was a 57-year-old Caucasian female with COPD who was referred with an incidental finding of an elevated calcium, and back in 2009 we diagnosed her with mild primary hyperparathyroidism, and her calcium levels have always run quite low, between 2.45 and 2.64, with only 2 or 3 occasions when she was actually hypercalcemic, and the PTH was mildly elevated. We did do a calcium load test, and 3 hours post a 1 gram calcium load, her peak calcium was 2.68, and at that time the PTH was not suppressed, so pretty sure on the diagnosis. Her mother had had primary hyperparathyroidism, and so actually we did a genetic screen and this all came back negative. So then we looked for complications, and a bone mineral density scan back in 2009 just showed mild osteopenia at all 3 sites, with the distal third radius slightly worse than the other 2 sites. And on imaging, she had no vertebral fractures and she had no history of stones or on imaging. And we actually did a FRAX assessment, which had only just come in, and this showed her assessment for major osteoporotic fracture was 9.3% and hip fracture 1.0%, using the primary hyperparathyroidism as a secondary risk factor. So recently, the 5th edition of the guidelines has been published, which were first published in 1990. And essentially, they recommend surgery if any of these criteria are met. So for instance, if the serum calcium goes to greater than 0.25 millimoles liter above the upper limit of normal. In the latest edition, they've changed the hypercalciuria guidelines to the normal ranges for the population. So for females, they're gender specific. So for females greater than 250 milligrams or 6.25 millimoles, and for men greater than 300 milligrams or 7.5 millimoles. So clearly this is going to be a lot more sensitive, but the positive predictive value is quite low at only around 30%. They've also gradually enhanced the guidelines for bone over the years, and so now we're expected to do a bone mineral density looking for osteoporosis at any of the 3 sites, and also to assess for silent vertebral fractures that won't be known about by doing vertebral imaging. But I think a really important comment is this at the bottom, which is that parathyroid surgery is the only definitive treatment for primary hyperparathyroidism, and it's always an option, even among those who do not meet the guidelines for surgery. So Our Lady did not meet the guidelines for surgery, and we offered surgery, but she preferred conservative management. Well, we have nice data now that we could reassure people with. So this is the Scandinavian investigation of primary hyperparathyroidism, which is the only long-term prospective randomized controlled trial that's been done, looking at 191 patients and following them up for 10 years. Now, of course, they used the 1990 criteria for inclusion. Now, calcium levels, if you look here, over time, do not alter significantly and are very stable in the observation group in blue. 4 cases converted to surgery because calcium levels rose, and so that's less than a 1 in 15 risk. So that's pretty reassuring. A second reassuring study is this latest one, showing that kidney function does not decline more rapidly than normal unless calcium levels are greater than 0.25 millimoles a litre above the upper limit of normal, i.e. hitting surgical guidelines. So it's a big retrospective cohort from the Kaiser Permanente database, which covers 12 South Californian centers. So it's over 6,000 patients, and they used 16,000 controls. And what you can see is they tracked EGFR from more than 5 years before the time of diagnosis. That was an inclusion criteria, with 5-year follow-up. And what can be seen in the black line here is that in normal controls, the EGFR is dropping by about 1 ml per minute per year. But if your calcium level was 2.88 to 2.99, it dropped at 50% higher, 1.5 mils. And if your calcium level was greater than 2.99, here in yellow, it dropped at double the normal rate at 2 mils per year. So this is the first data of its kind. And what's interesting is it actually declines before the diagnosis of primary hyperparathyroidism is made here. And furthermore, they showed that when you operated, the decline was stopped. So the latest guidelines simplify management in medically treated asymptomatic patients. And essentially, you have to do a serum calcium and a serum creatinine annually. And now they want a vitamin D level, which they want above 75 nanomoles a litre. So do not be afraid of vitamin D replacement. Meta-analyses and a large randomized controlled trial from Denmark show convincingly that serum calcium levels and urine calcium levels do not rise. PTH levels go down, reabsorption markers go down, and lumbar spine density actually improves. So it is perfectly safe. They also recommend serum creatinine annually, but slightly difficult. They actually recommend a creatinine clearance on a 24-hour urine every year rather than using an estimated GFR, which is quite a lot of work. On bone mineral density, they recommend every 1 to 2 years that you repeat 3-site densities, but other imaging only if clinically indicated. So to follow up in case 1, things were very uneventful for 12 years, but then during COVID, she took her granddaughter down to the beach and slipped into a pothole, and she broke her left radial head and scaphoid. She fractured the left metatarsal base on the 5th metatarsal. So we reworked her up for operation when we saw her again and found a right inferior parathyroid adenoma on ultrasound and sestamibi. But what was interesting was that her DEXA at the time showed she'd lost quite substantial bone density at the femoral neck of 10.3%, which was more than the other 2 sites. Whilst we were working up, she had a trip in her bedroom during the night, fractured 3 ribs, and on CT was shown to have a T12 superior end plate fracture. So actually we started her on treatment pending operation with a stat dose of IV zoledronate. You should ensure that people are on a good calcium intake, so 1.2 grams a day are the guidelines according to the Institute of Medicine recommended calcium intake per age. We also were giving her 2,000 units of cholecalciferol, and as a rule of thumb, you can think that 400 units would give you a 10 nanomole per litre rise to hit the 75 required. So this is her bone mineral density over time. And I think what is interesting here is that since the last scan, she's actually lost substantial bone density at the femoral neck at 7.2% and at the radius of 5.4%. And this is actually what's been seen in observation studies. So this is the famous Columbia University cohort, which was started in 1984. And what they show here is a change in bone mineral density versus time. And of course, the follow-up population dropped over time because a lot of people converted to surgery or lost to follow-up. But it clearly shows that after about 8 years, there's a statistically significant drop at femoral neck and radius, but also that the magnitude becomes more and more significant. So this is probably what Our Lady is showing. So I'd now like to have a quick look at the evidence for bone risk and the benefit of surgical intervention in primary hyperparathyroidism. So this, we don't really have any randomized controlled trials, so that besides the one I mentioned. So we're reliant on retrospective cohort data, and this is a very good group at the Mayo Clinic under Kozler, and they've got very good databases which cover the whole of Rochester County. So what they did was looked at 407 patients, and they compared their rates of fracture to gender and age in the same population, giving a standardized incidence ratio. And what's interesting is that the vertebral fracture rate is markedly elevated at 3.2 times, and the distal forearm, ribs, and pelvic fracture rates are all more than twice normal. The proximal femur fracture rate wasn't elevated, and the significance intervals actually cross on 1 there. A second study, which was from Denmark, based on 3 centres, one of which is very famous for epidemiology and it's good data. And they looked at 674 patients and 3 times matched controls, and they show very similarly. I would just say that this was not an asymptomatic group. They had quite high calcium levels, mean of 2.93, and 1 in 4 had had a history of kidney stones. So it's really all comers. But what they show is that the relative risk pre-surgery for all fractures was 1.8 times. And again, at vertebra, very high, 3.5, and at forearm and lower leg and ankle, just around twice. Femoral neck, again, was not statistically significant. And importantly, post-surgery, they can show that that risk goes down to the same level as the controls. What's particularly nice from this group, though, is that they analysed over time. And so they looked pre and post-surgery at what happened to fracture rates. Post-surgery, you can see that at 1 year, the fracture rate is still elevated, and that, of course, corresponds to bone recovering and remineralizing. But after 2 years, fracture rates have dropped back to normal, although after 10 years, there's an increase due to forearm fractures. They looked at risk predictors, and funnily enough, the severity of the primary hyperparathyroidism really didn't matter. Actually, the standard factors mattered: age, sex, and prior fracture, things that are already in FRAX. They also looked at the relative risk of fracture prior to surgery, and interestingly enough, that's quite marked almost up to 10 years before. So this either says that during the normocalcemic phase, when you're developing primary hyperparathyroidism, that you are actually at risk and bone is being demineralized, but it also might just suggest that it brings out fractures in those who were already predisposed. And I think that's slightly backed up by the fact that if you'd had a fracture prior to surgery, then your risk post-surgery did not go back to normal, but actually you were still at twice the risk. So that is a population who we should be following up longer term in our clinic. Bigger retrospective data actually can show us that hip fracture rates are altered. So this is an enormous cohort from Sweden, basically the whole country, over 16,000 cases over a decade. And what you can see here is a cumulative incidence of hip fractures, and you can see it diverges within a couple of years, and the relative risk of hip fracture here compared to controls is 1.5 times. What is interesting is we don't always operate on the people who are at high risk. So this is all this Swedish data showing who's been operated on and who hasn't, and illustrating the baseline criteria. What's interesting is that the conservative group are on average about a decade older, have a higher incidence of fractures, have a higher incidence of osteoporosis, and have a markedly higher incidence of comorbidities such as cerebrovascular disease, dementia. And so if you try and compare fracture outcome between those two groups, it doesn't really work. It's sort of fundamentally flawed, because clearly the conservative group are at much higher risk of fracture. They have all the main risk factors. And so I'd just be cautious of many studies where that bias in the baseline characteristics is not properly accounted for. I think it's difficult to control it out. But what this group did was really clever. So what they did was they say, let's look at people longitudinally pre and post surgery. And it's impressively fast in Sweden that they managed to operate within half a year, so 0.48. And then they had 5 years of follow-up. And if you look, what they did was they worked out the incident rates of fracture per 1,000 person years, pre and post surgery, and showed that surgery reduced the odds of fracture to 0.77 times for any fracture and 0.75 times for osteoporotic fractures. So given this is following individuals longitudinally, I think this is very strong data. Clearly what we want are randomized controlled trials, and we've had 4 of them in asymptomatic primary hyperparathyroidism. And of course, the good news is they're randomized, they are asymptomatic disease, and you can see they've got very mildly elevated calcium levels, all less than 0.1 millimoles above the upper limit of normal. The only problem is that all these studies started a long time ago, so they used the 1990 inclusion and surgical indications. So their bone mineral density was only measured at the forearm, and a number of the cases in these studies had osteoporosis at the lumbar spine or femoral neck. They also excluded early postmenopausal women because of the increased rate of bone turnover and bone interfering medications, except this large Boleslev study allowed people to be on HRT. And this is an analysis of the outcome. And what you can see is that in all the groups combined, it's about a 4.2% increase compared to placebo in the lumbar spine bone density at 1 year, and about 3.5 at the femoral neck. And interestingly, this compares fairly similarly to 3 randomized controls of bisphosphonate that gave 5% and 2.9% respectively. Change in the distal radius, though, was not significant, and that again compares to bisphosphonates where there is no significant change. And I think an interesting point is that these percentages are quite small compared to what we've seen in observational cohorts, and it tells you the benefit of doing randomization. Well, Our Lady was not osteoporotic, and that population had quite a few osteoporotic patients in it. So does it apply? Well, Ambrogini in his study looked at the osteoporotic and non-osteoporotic subgroups, and what he showed very nicely was that the lumbar spine increase of 4.1% difference here, and at total hip 4.9% difference, was just as significant in the non-osteoporotic patients. So our patient would benefit. That Boleslev study was the only one which followed out to 10 years, and it was based on 191 patients, and of course they had some dropout. The baseline lumbar spine T-scores were actually mildly osteopenic, and what they showed over time is that at lumbar spine, here in blue, the observation group is fairly stable and only loses about 2.16%. The surgical group, as we know, increase a lot during the first year, and this gain is actually maintained at 10 years, such that between the groups there's about a 6.4% difference, which represents over half a T-score. They did screen for vertebral fractures by X-ray, but actually there was no difference, and 7 patients in each group were affected. So this is at femoral neck. What you can see is, again, they have osteopenia. In the surgical group, what can be seen is that actually they don't have an increase in bone density. There's a non-statistically significant loss of 1.8% at 10 years. But what's interesting is that the observation group are losing quite markedly, a total of 7.7%. So there is still a big difference between groups after 10 years of 5.9%. And the distal radius data is rather disappointing. So again, at baseline, slightly worse densities. But actually what happens is that both the surgical group and the observation group lose density at the radius, 5.4% in the surgical group and 10.4% in the observation group. So it's a bit disappointing, but clearly you can see that the lines are diverging, so that there is a benefit to surgery, and the fracture risk in the non-surgical group is obviously going to be increasing. Their study wasn't really powered for peripheral fracture rates or vertebral fracture rates because their recruitment stalled and they weren't able to achieve the numbers they wanted. And so there were in fact 22 events in each group, and so no difference, but I don't think they had the statistical power to sense difference. So we're rather disappointed about the radial data, and I would just say one thing, that are we measuring the right thing? Because bone mineral density studies are aerial, and aerial bone mineral density is affected by bone size. And in primary hyperparathyroidism, rather like in postmenopausal time, the bone size actually increases, so the total radial area is increased. So from this nice study from Kobe University, they used peripheral quantitative CT so that you could measure volumetric bone mineral density. And here we are post-surgery, 1 year. What you can see is that the cortical volumetric bone density actually does increase, and the cortical area and cortical thickness more substantially. So perhaps we are not doing the right measurements. And I'd also say that they looked at strength indices, and these measurements on calculation showed an increase in bone strength. So that's quite positive. So the consensus guidelines from 2008 recognized a long-term decline in bone mineral density in untreated patients. And they said basically new data on the natural history of asymptomatic primary hyperparathyroidism have favored surgery because bone density doesn't seem to be indefinitely stable, particularly the Columbia University cohort I showed you. So there's growing consensus that surgery may eventually be appropriate in the majority of patients, and a more proactive approach should be recommended. So perhaps we should be more persuasive with Our Lady. And finally, a final thought, which is that we have a bone mineral density cutoff for osteoporosis of -2.5, and that's what we're using in the parathyroid guidelines. But actually there's good data showing that fracture threshold may be altered in primary hyperparathyroidism, rather like it is in people on steroids. And so this is a very nice study from PISA, and what they looked at was 150 primary hyperparathyroid postmenopausal women, comparing to 300 controls who were matched for age and postmenopausal time. And what you can see is the fracture rate was 25% of prevalent fractures in the primary hyperparathyroid group and only 4% in the controls. But what's more interesting is that it doesn't respect bone mineral density. And you can see in the highest quartile of bone mineral density here, with T-scores better than -1.5, there were still multiple patients with fractures. So I suppose our conclusion, and looking at our case, is could our risk assessment be improved? Could we change the bone mineral density threshold, rather like we've changed the hypercalciuria one? Or could we use a modification to use FRAX to estimate what these people's real risk is? Thank you.
Thank you, Dr. Scott, for summarising the evidence base so clearly. There's a couple of questions about vitamin D replacement, mainly a hypercalcemic patient with a low vitamin D. Is it safe to give high dose vitamin D, i.e. 40,000 weekly for 6 weeks, in someone who's hyperpara with vitamin D of less than 15, for example?
Absolutely, it's safe, and maybe I could just show you. There we are. So this is actually from a big study from Rolliged in Denmark, A meta-analysis of other studies has shown it's absolutely safe, and he shows it very nicely here that actually in the vitamin D group there is no increase in plasma calcium levels prior to surgery, no significant increase, and there's no significant increase in 24-hour urine calcium. In fact, if you restrict vitamin D, what you actually do is make the parathyroid adenoma grow more, and that's been shown in other studies.
So would you go for 20,000 or 40,000 yourself weekly in these patients?
Well, I think the guidelines will generally say be a bit cautious, and I think the rule of thumb whereby 400 units will probably take it up by 10 animals and try and aim for the guideline 75 cutoff. I think 20,000 units weekly is probably plenty. In fact, a study by Gray from New Zealand, he actually showed 50,000 units was safe. So you know, I think we can be pretty sanguine about this.
Thank you. So someone's one of our colleagues in the audience has done a quick maths calculation. So if 400 raises vitamin D by 10, then should 300,000 over 6 weeks increases to more than 715 animals?
Well, of course, it's due to saturation of fat depots. And when you change dose, actually what happens by 12 weeks, you've reached a plateau level. And so no, that won't happen. What we're saying is that at a steady state level as it's reached, you know, 400 units will be 10 animals more. That's 400 units per day. And you're talking 20,000 units weekly. So that's obviously a bit different. But yeah, if you're worried, watch and see. You'll reach a sort of plateau level by about 12 weeks.
Thank you. And one last question before we move on to our final talk. Bisphosphonates for osteoporosis in a patient awaiting parathyroid surgery.
Yes, well, I suppose first we have to say that we've got a bit of a backlog post-COVID in the UK, and she'd fractured again whilst we were still working her up, and we needed an anaesthetic opinion, Ray, her COPD. Generally, we avoid it, and that's because the bone regain post-surgery would be better without a bisphosphonate. Clearly, bone formation and reabsorption are linked, and therefore you will have an effect on the bone remineralization and reformation. Having said that, modern bisphosphonates are less of a problem on bone formation than the old ones. But what people worry about is post-operative hypocalcemia, and clearly in the first 24 hours you won't be able to mobilize bone, so you would be at risk. But the hungry bone syndrome that then occurs as you remineralize, you could argue that that might be improved, but the data doesn't really show that. There hasn't been a big study, and essentially I think we can be pretty reassured because we've got a number of people in whom we've done it.
Thank you so much once again, Dr. Cox. We're now going to move to our final talk of the bone and calcium masterclass. So in our masterclass series, we make sure that we've got at least one surgeon in our speakers, and it's my pleasure to introduce Miss Aimee Di Marco, who is consultant endocrine surgeon at Imperial College and also heads the anatomy and surgery teaching in the School of Medicine. And she's going to share with us a couple of cases from her practice.
What I'm going to do is discuss a surgical perspective generally and the types of surgery which one can offer to patients. And then I'm going to use 3 different cases in order to illustrate those points. And we will discuss some of the possibly available surgical adjuncts. So what do I do when I meet a patient with presumed primary hyperparathyroidism in clinic? So while we're blessed at Imperial and in the UK in general with patients who come very well worked up with regard to their biochemical diagnosis, I nonetheless like to confirm it. So the first thing is to confirm the diagnosis and then to start thinking about what the goal of treatment is, i.e., does this patient have any end organ damage and to what degree? And to what extent is it likely that I will benefit that end organ damage? And to what extent is it appropriate in the context of the patient's other comorbidities and their age, etc. Once I've satisfied myself of all of those points, then it's time to move on to surgical planning. in which the question is really how to achieve the goal of curing the patient with a minimum of risk. And that will involve some imaging, which I'll talk about, and it involves a full and frank two-way discussion with the patient. So when checking the diagnosis, as I said, all of our patients come beautifully worked up, but one has to be alert for a few pitfalls that occasionally can trap even the most experienced of endocrinologists or surgeon. So obviously we want to look out for patients who may have FHH, patients with undiagnosed MEN1, patients who are masquerading as primary hyperparathyroidism, who in fact have vitamin D deficiency, a drug relating to their hypercalcemia, or who have other rare genetic conditions which can mimic primary hyperpara biochemically. And so the first thing to do, obviously, is to take a history, both of the presentation and a family history, in order to see if any alarm bells are rung. And the next thing to do is simply to have a look at the biochemistry. And that's the biochemistry which I do, which is completely standard. So a serum, corrected calcium, phosphate, PTH, vitamin D, renal function, and then preferably a 24-hour urinary calcium and creatinine. Once I'm happy with that, I discuss with the patient their presence or absence of end organ damage and symptomatology, and obviously talk through their comorbidities. In general terms, if there's an absence of any gross hypercalcemia and an absence of any really significant end organ damage, then we may be talking about a situation in which a patient needs to have at least a 10-year life expectancy in order to benefit from parathyroidectomy. And so it's important to start to understand the patient in that context. So again, once I've satisfied myself that we've reached the diagnosis, we're going to do some good, then it's time to start surgical planning. And it's only then really that imaging comes into play. And it's the imaging which selects what type of procedure I will offer the patient. I'll come on to that in a minute. In terms of how to achieve the goal while minimising the risk, we all know there's good data behind having a high-volume multidisciplinary service treating a patient, both from the point of view of endocrinology, anaesthesia, nursing care, as well as surgical care. There is some evidence for the use of intraoperative adjuncts, both to reduce complications and to improve cure rates, but it's not necessarily as robust as one may think, with the exception of nerve monitoring, which has been shown to reduce the incidence of recurrent laryngeal nerve palsy due to nerve injury. So in terms of what types of surgery, there are all kinds of different names given to the types of surgeries which we do, but broadly there are two. So broadly, if a patient has positive imaging, they will be potentially a candidate for a surgery which targets that image-guided parathyroid adenoma. And that can be done either through a central scar in the neck with mobilization of one thyroid lobe and inspection unilaterally, or it can be done by making a more laterally placed smaller scar and simply targeting directly onto that adenoma seen in the imaging. And so there are all kinds of different ways in which these operations are labelled. You may see them called a focused lateral approach, a minimally invasive parathyroidectomy, or MIP, or you may see them referred to as unilateral targeted surgery. But broadly, it's about whether the imaging is positive enough to justify just targeting that gland. And the only other alternative is a surgery in a patient whose imaging is more questionable, in whom the aim is to inspect all 4 parathyroid glands. And both of those are done in the full knowledge that even if you have good localization at the outset, you may still, as I put up here, be dealing with a situation in which you have an unexpected double adenoma or multi-gland disease. So here's our first case. We've got a 62-year-old man who works in publishing and feels fairly well in himself, who's had an incidental finding of hypercalcemia in the absence of any family history. Of interest to me as a surgeon, he's had a previous cervical spinal fusion, and he's had that through an anterior approach. So he essentially has a thyroidectomy type incision in the anterior aspect of his neck already. That's his biochemistry. So he's got a calcium of 2.7, which is 10.8 in milligrams per deciliter. He's got an inappropriately elevated parathyroid hormone. He's got a kind of adequate vitamin D. It's not particularly low. It could do with some improvement, but it's unlikely to be the cause of his problems. And he's got a convincing 24-hour urinary calcium and calcium creatinine clearance ratio that seems to exclude FHH. He's had no history of renal tract calculi, and his renal imaging is unremarkable. His bone mineral density, particularly at the lumbar spine, seems to be a little questionable, particularly in the context of a 60-year-old man. So he's got some mild osteopenia. So the first question is obviously whether he will benefit from surgery. So he has a calcium of 2.7, he's 60-ish years of age and otherwise in very good health. And so that alone, even in the absence of osteopenia, I would judge him as someone who will have benefit in correcting his biochemistry, most probably benefit from his cardiovascular system as well. So it's on that basis that I believe, and the endocrinologist who referred him believes that it would be reasonable to undertake curative surgery for him. So we go on to do some imaging. So at Imperial, we still deploy two modalities of imaging, predominantly Sestamibi and ultrasound in whichever order. And that's his Sestamibi saved screens. So I'm sure you can all see reasonably clearly, even on the 10-minute, that there's a bright spot overlying his right thyroid lobe towards the inferior aspect of it, and that's maintained at 90 minutes. So that looks fairly likely to be a parathyroid adenoma. I always look at the axial sections. As a surgeon, this is of particular interest because it helps you determine whether you think that this is going to be an inferior or a superior parathyroid gland. And that's largely determined by how anterior or posterior the gland is. This is actually quite posterior in relation to the thyroid gland, and so it could be a superior parathyroid gland, even though it's about at the level of the clavicular heads. So it could really be either. And this man has a concordant ultrasound. So what would we like to do? So we could manage him medically. His calcium's not that high and he's only got some osteopenia. We could do a 4D CT or a choline PET, or we could decide that we're going to undertake some surgery. A literal handful of votes for medical management and for some more imaging. We've got a couple of people who would prefer him to have a full gland inspection, but the majority seem to be opting towards targeted surgery. Now, I am interested in the idea that he would be managed medically, given that he's young enough to benefit, that he has a calcium of 2.7 and he has a minor amount of osteopenia. I would certainly think that assuming he is cured, he would benefit. So then the question is about whether he's ready for surgery. Now, he's got fairly decent concordant imaging. And so he, to my mind, has two options. He could be offered full gland inspection or he could be offered targeted surgery. But there's one thing that we can't forget with him, which is that he has a prior neck incision. And so he has a scarred neck. And that increases the risk of intervening approximately tenfold with regard to injury to the recurrent laryngeal nerve and hematoma. So if one is going to intervene on a patient who's already had some surgery, it's generally advisable that that's going to be targeted surgery, which is what I did. So I went through his previous spinal fusion scar, opening up just the right-hand side where the parathyroid was located based on the imaging, and found and removed his parathyroid after localizing and preserving his recurrent laryngeal nerve. And that is the specimen, which was histologically proven to be a parathyroid adenoma. He had interrupted PTH measurement conducted during surgery, which you can see from my scroll here. So you can see where it says IOPTH, he's got a pre-op level in the anaesthetic room of 9.8, which rises to a peak of 24 and drops at 5 minutes to 7.7. So more than 50% drop by 5 minutes from the pre-excision level gives a 99% chance based on our criteria that he is cured. And he had a nerve monitor used, which is particularly important in the context of risk reduction in someone who has a scarred neck. So he is cured with a confirmed histological diagnosis and will have his bone mineral density followed. So I mentioned that we used interrupted PTH in him. Now, are we justified in so doing? Actually, the evidence is not strong in using interrupted PTH measurement in first-time surgery. But I would say that interrupted PTH measurement has been approved by NICE for use in reoperative surgery. So while this man hadn't had a previous parathyroidectomy, he did have a scarred neck and was therefore at higher risk, i.e. you need to be able to target the parathyroid more specifically. And so actually using interrupted PTH in him would seem a sensible thing to do. But there's high quality data from large series that you can conduct focused parathyroid surgery without interrupted PTH measurement and have very good outcomes. So this is a study in which I was involved when I was in Sydney about 5-6 years back. And we looked retrospectively at 3,000 parathyroidectomies, comparing the open and focused approaches, and found no significant difference in cure rate in the absence of interrupted PTH. Okay, so time for another case. So this time we've got a man of 41 years of age who does have renal calculi, no family history, he's fit and healthy and works an active job as a hairdresser, and that's his biochemistry. So he's got a relatively modest elevation in his corrected calcium of 2.65. He's got an inappropriately elevated PTH of 16. He's got a fairly good vitamin D. He's got a convincing urinary calcium and a ratio. So he went on to have some genetic testing in view of his age and the fact that probably he had had this for some time, and his genetic testing for both MEN and for FHH was negative. So based on his age and his renal tract calculi, my opinion was that he would benefit from surgery. So we went ahead and did some imaging. So the SESTA-MIBI scan essentially says nothing's seen. There's possibly some low-level uptake. And they recommended an ultrasound scan. And there's nothing on the axial images either in terms of a mass lesion. The ultrasound scan says, also nothing definite, maybe something just at the inferior aspect of the right thyroid lobe, but possibly it was a lymph node or an exophytic thyroid nodule. So he's got quite mild disease. He has got renal calculi. What would you like to do with him? So let's put that to the Menti as well. So this is interesting, and these are all kind of reasonable approaches. So I think if you were to monitor and defer a patient of the age of 41, the likely endpoint is that his calcium will take off at some juncture. And the concern is obviously that with his known previous renal tract calculi, that he may have formation of further renal tract calculi and deterioration in his renal function. So we discounted that, but obviously this is all based on your local ability to access either imaging or surgery, and successful surgery. So my practice, and in our institutions, we don't perform any further preoperative imaging in this context. So the diagnosis is clear. The preoperative imaging may be negative, but as long as you have somebody who's confident in performing foregland inspection, it's not really necessary to undertake more imaging. So that's how we practice here at Imperial between myself and my two colleagues, Professor Palazzo and Professor Tolley. So I prefer to label this as a foregland inspection because patients find the description of a foregland exploration somewhat intimidating as an idea, and I think they view it as a rather unguided type of a description of surgery, which is actually very focused on specific anatomical areas. But nonetheless, in order to minimise risk and to optimise the cure rate in this situation, the standard approach is the patient has a preoperative vocal cord check with me in the anaesthetic room. They have a nerve monitoring NIM tube so that I can check in real time the function of their recurrent laryngeal nerves. They may or may not have antibiotics depending on their risk profile for infection. They'll have a small central transverse incision of 3 or 4 centimetres unless they have a goiter. And in order to reduce the risk of hematoma, they will have a clear clarification of good dryness and good hemostasis at the end of surgery, and will not be given any clexane, given that DVT is not a risk in this population. And the aim of the surgery is not just to visualize the abnormal gland, but really importantly to visualize the normal, so that you have a comparator and so that you're clear on your anatomy about where the abnormal gland is likely to be. So just by way of illustration, I'm not going to show you all of the glands, but I'll show you a normal and an abnormal. So this is a transverse incision. So the patient's head is towards the left of your screen. The patient's feet are towards the right. So we're now looking at the left thyroid lobe being retracted by the larger retractor, and the forceps are pointing at a normal left inferior parathyroid gland. That's a normal gland. And this is an abnormal right inferior parathyroid gland in the same patient. It's not big. You can see that small swab there is what we call a surgical peanut, so it's under 1 centimetre. But that's an abnormal right inferior, and that's a normal left inferior. The two upper glands also visualised, and they were normal. So this gland was removed, and I have the luxury of autofluorescence, which is interesting because it selectively fluoresces hyperplastic and normal parathyroid tissue, but the adenomatous proliferation of cells, the clonal proliferation, does not fluoresce. So immediately I know that this is an adenoma and not a hyperplastic gland. So this patient was cured. Their postoperative calcium fell, interestingly, quite slowly from 2.5 on the first evening after surgery to 2.1 on day 1, and their PTH fell nicely as well. And they'll have long-term follow-up. So same question, is our approach in taking patients with negative imaging or questionable imaging directly to parathyroidectomy justified? Well, as I said, this completely depends on a local context and the experience and volume of the unit in which a patient's looked after. And so our data between myself and my 2 colleagues was analysed a few years back. And interestingly, we found that actually only 40% of our patients are both ultrasound and sestamibi positive, i.e. dual concordant, like our first patient. The remainder are either double negative, that accounts for about 1/3 of our patients, or they have only one imaging modality positive. And yet when we looked at our cure rates, overall we found a cure rate of nearly 98%. And importantly, we didn't find a statistically significant difference between the groups. You can see that in double negative disease, there's a minor tendency towards a lower cure rate at 96%, but it is not statistically significant. And so on that basis, we feel justified in our approach. So I'm going to move on to our third case now. So this is a 43-year-old who had an initial diagnosis of primary hyperparathyroidism made about 15 years before we met them. They'd had 2 episodes of renal tract calculi, and they had had 3 previous operations on their neck, 2 undertaken in the UK at a 6-year interval, during one of which, importantly, a left hemithyroidectomy was performed. They then went to a centre in the United States of America in Florida and had the right neck explored with guidance of the gamma probe, but again, no parathyroid was found or removed. And they remained uncured with persistent disease and the biochemistry unchanged. So the patient had their biochemistry repeated, and it was found that their corrected calcium ranged between 2.76 and 3 millimoles per litre with an inappropriately unsuppressed and sometimes elevated PTH. They had a convincing urinary calcium and a convincing calcium creatinine clearance ratio on the 24-hour urine. Now, in this situation, unlike the first patient who had a scarred neck but who hadn't had previous parathyroid surgery, it's even more important to be tight on the imaging. And we tend to go back to basics, and after confirming the diagnosis, would re-review all of the old imaging before undertaking any new imaging in order to get as many clues as possible. So we found that the last ultrasound undertaken was negative, that the patient had had an MRI, and I would stress MRI is not a good modality for imaging parathyroid glands. That had been undertaken at the referring hospital, and that was also negative. So we reviewed a sestamibi scan subsequently, and what you can see is that the contrast is taken up by the remnant right thyroid lobe, and that kind of muddies the waters somewhat. So there's a blank area in the left of the neck, and sestamibi taken up intensely by that right thyroid, but there's not really anything else. We have to call that negative. So we did a 4D CT, and on the 4D CT, we wondered about this. You can just see a small ovoid lesion in the anterior mediastinum, which takes up contrast quite avidly. So this is a possible candidate for a thoracic ectopic parathyroid. But before you take somebody to theatre who has had 3 previous operations on their neck, and before you submit them to an operation, particularly on their chest, obviously it's important to have as much information as possible. So at this juncture, this patient was looked after before the advent of choline PET. And so they underwent initially an angiogram performed by Dr. James Jackson. And interestingly, that just shows the C trachea outlined beautifully here. Obviously, this is the catheter, and this is the right thyroid lobe, but there's nothing else. There's no blush anywhere. So we had to think again, and again, before the advent of choline PET, our next step was to undertake venous sampling. So Dr. Jackson again performed a series of samples, sampling the venous drainage of the potential locations of an ectopic parathyroid, and found that in the thymic vein, there was a 10 times baseline reading of PTH, which is consistent with the same area seen on 4D CT. So we've now got a similar question. Are we going to manage this patient medically, or are we convinced enough by the imaging that we think that they should undergo surgery? If we do think that they should undergo surgery, what would be the most appropriate selection of surgery for them? Is this something that you would recommend, or you've seen mostly approached with an open sternal split or a thoracoscopic approach? Now, I have to say that putting further imaging in there was probably something of a googly, because at the time, as I say, we didn't have access to choline PET. Had this same patient been assessed now, following on from a 4D CT, our next selection of imaging would have been a choline PET. But if the choline PET was negative or unconvincing, we would still be requesting that interventional radiology undertake an angiogram and venous sampling. So this is good that we're all in agreement, and that you all came to the same conclusion as our MDT. So this is a slightly grainy video, unfortunately, but this is demonstrating the thoracoscopic approach. You can see here is this is the lung, that's the heart here in the pericardium that you're looking at the top of the screen. And the white structure running between the two is the phrenic nerve. So this is my colleague, Professor Palazzo, operating, and I'm holding the camera for this case. And what he's doing is mobilizing in an en bloc fashion all of the thymus within the thorax off the pericardium, because even though we know that there is a parathyroid within that tissue, it's impossible to say exactly where it is. And it's not possible to go probing within the thymus to localize the parathyroid without causing bleeding or damage. So the approach is to resect all of the thymus en bloc. This patient again would have had intraoperative parathyroid hormone measurements, so that at least once that thymus was removed, it would be possible to confirm that the PTH had dropped appropriately. Okay, so post-operatively, he was cured. Not completely unexpectedly, he was relatively hypoparathyroid initially post-operatively, but that actually recovered. And although this reports his progress at 3 weeks, this patient keeps in touch with us on an annual basis and is now off treatment. And those are the small scars with which he's left. Again, that's an early photo taken just a few weeks after surgery. So they've since healed up. So in conclusion, I hope that I have explained to you the mysteries of the surgical consulting room and what we discuss with patients outside of just a surgical consent, that we re-explore diagnostics and that there is a role for that we re-explore the indication, and that based on that and based on the imaging, we plan the surgical strategy. We've talked through a variety of cases from localised to unlocalised ectopic disease. And I hope that that has been of interest and use to you. Happy to take any questions. And I should say, even more importantly, that if you scan this QR code and give your feedback regarding this evening's symposium, you will then also be able, I think, to receive your CPD points once the feedback has been submitted. So please do scan the QR code with your phones and give your feedback. Thank you very, very much for your attention.
Thank you very much indeed for a really clear and informative talk, Aimee. Just to reiterate, the QR code is there. The Masterclass is accredited by both the Royal College of Physicians in London and Department of Health in Abu Dhabi, so please do scan. It's a quick feedback questionnaire, and then you'll get your certificate immediately emailed to you. A couple of quick questions. I know we've reached 4 o'clock UK, 8 p.m. Abu Dhabi, but in a patient with MEN1 and hyperparathyroidism, where you've got clear imaging, will you still do a exploration, we should now say inspection, for gland inspection?
That is a fantastic question, and actually we could have a whole another half-hour discussion and more on it, because there isn't consensus, as you will know, across the international community about that. So again, it's about assessing the patient in their context. And particularly with regard to their age at presentation. So the way in which you manage a 17, 18-year-old presenting for the first time with hypercalcemia in the context of MEN1 versus a 40-year-old is quite different. Clearly, with the underlying pathology being something that will produce asynchronous enlargement and abnormality of all parathyroid glands, guaranteed at some juncture. What one is expecting is that unless all parathyroids are removed at the first surgery, which is not recommended because it will render the patient hypopara with as many different problems as they already have. So unless you were to do that, any operation that you do in the first instance will be followed by another operation. So this becomes a question of both understanding the benefit to the patient at that juncture and based on their age and on their imaging, and of planning ahead for their second surgery and discussing with them what their attitude towards that is. So in a patient in their late teens, early 20s, for instance, who's already got the indications for parathyroidectomy, who has strong imaging, in that context, our MDT will quite commonly recommend that we conduct targeted surgery, but by that I mean unilateral surgery through a central incision, and we clear one side of the neck. So you take 2 parathyroids, leaving the other 2. We would not generally selectively take just 1 parathyroid, because you're leaving yourself then open to 3 more in the future, causing problems, and to having to go back in a scarred neck on the same side. In patients who've reached the more common age of 30 to 40, even with positive imaging, our approach would be a subtotal parathyroidectomy, leaving them with usually a half, or on occasion 1 parathyroid if it's small and relatively normal looking, because then they will know that they will get as long a period of normocalcemia as is possible. We aim for about 10 years before their second and final surgery becomes necessary. And this is a situation which involves a really in-depth discussion with the patient in order that they understand this, and they understand that this is a journey that you will take with them over the coming years, essentially. Sorry, that was a very long answer.
Thank you. No, very helpful and informative. Okay, so make sure you scan the QR code or use the link to get your certificate and the associated accreditation. I'd like to thank our speakers again, and remember to put 3rd of May, Friday 3rd of May, the Thyroid Masterclass in your diaries. Have a lovely weekend.